Says get ready. All right. We are live and we are recording. Hello, everyone, and welcome to DocTalk, our first live webinar. I am Dr. Erin Knopf.
I'm Dr. Corinne Hannan.
And you can check out our bios and meet your recovery team in the community. Today's topic is a little broad, but we're also going to try to narrow in. So I promise, stick with us. But one of the big things we want to answer today is what is the difference between eating disorders and disordered eating? We're also going to explore diagnostic considerations, social and cultural influences, and discuss why support is important for both. You ready, Dr. Hannan?
I'm ready. Let's do this.
Let's do this. Okay. So first and foremost, what is an eating disorder? How do you like to talk about that general first response?
That's a great question. Eating disorders are really complicated illnesses. They aren't something that you can describe really simply or like in a reductionistic way. They're neurologically based, but they're also influenced by environment and culture, also stress. So we like to say they're a neurobiological, neuropsychological disease. So it's about food, but it's also really not about food. It's about so many more factors than food. It runs in families, and then there are strong cultural elements that can really influence the development of an eating disorder.
Totally. If anything, I think I like to add that it's often just it serves as an expression of psychological needs and one's psychological state. There's usually a lot going on underneath the surface that influences why someone turns to maladaptive coping strategies around food and movement and body preoccupations. And really, they don't discriminate. I think a lot of people have misconceptions, especially physicians, that we all have come to realize that this is not a disease of just white, cisgender, thin, affluent females. This is in everyone. It doesn't discriminate. It occurs in all genders, all races, all socioeconomic statuses. And people actually, in both average and large size bodies, can also experience starvation and malnutrition as much as someone who is, potentially looking more obvious for their emaciated condition. And what's really challenging, I think, is finding clinicians that understand the nuance of what the eating disorder is and isn't, and how to appropriately identify it and address it holistically.
Yeah, I think it's really important to know that if you need treatment for an eating disorder, you might not know yourself. You need to get a good assessment from somebody who knows what they're talking about. And so I'm going to use a metaphor with cancer a lot. So you can go to the GP and they might be like, you know what, you need to go see the oncologist. But once you know you have cancer, you're going to want to see a specialist for that. So the
Totally.
same is true with an eating disorder. You can go to a therapist, and if they're like, there might be something here, you might want to go get an assessment. You want a specialist with eating disorders. There's specific training that's really necessary to properly diagnose, assess, and treat eating disorders.
Totally. If anything, we get the questions a lot. Well, what kind of eating disorder do I have? And if anything, this is more for academic reasons. We're going to look at this graph, right? This shows the changes that happen from the DSM-4 to the DSM-5. That's the diagnostic manual we all rely on in the clinical field. But really and truly, we want to name that these diagnoses and labels don't fully encompass the true human experience and are not always clinically relevant or helpful, right? Like if anything, diagnoses can change, right?
Yes, sometimes they're kind of problematic and reductionistic. Like they reduce it down to the behaviors. And in treating eating disorders, those behaviors can change and be fluid. I've treated eating disorders in group settings as well. And people get really invested in like, well, what kind of eating disorder do you have? Well, mine's very different. And I think that overall misses the point. The eating disorders really are disorders of food and movement with underlying complex causes. So we address the food and movement, and then we get to the causes underneath it. But that, classifying it with a diagnosis is for ease of communication between practitioners. It's also for getting reimbursement from insurance companies or at the hospital, but it's not necessarily helpful and all-encompassing for the individual being treated, because they can change during the course of treatment. rather dramatically. Have you seen that in
Totally.
your practice as
Oh,
well?
yeah. Especially, when we start talking about behavior swapping, right? As you try to treat one presentation, then the mind wants to find something else to replace that behavior that someone is reducing or interrupting. If anything, when we think about this chart and the classification, I usually make it a lot more generic as far as, diagnoses can be divided out between intentional, unintentional weight loss or weight changes, I should say, too, or preoccupation with weight. Drive for thinness, fear of weight changes in general. Are there compensatory behaviors? And these can be really dramatically different, but they all have similar impacts on the body and the overall health of the individual as far as restriction, overexercising, laxative use, purging, diet pills, water loading, things like that. But really, truly, when we're doing work and we're helping someone find their values in life and reconnect with their life beyond their symptoms and the quote unquote criteria of each diagnosis, that's when we really see true traction and true improvement.
A perfect example of how the Diagnostic and Statistical Manual isn't the be all end all is the term atypical anorexia.
Yes.
Right?
Yes.
It's a fat phobic misnomer first and foremost, because the most typical presentation of anorexia is people with quote unquote normal or quote unquote overweight bodies. I say quote because over what weight? Like I don't like the term overweight, but and
Totally.
BMI we'll get into. It's very not it's not useful. But the vast majority of people with anorexia nervosa do not have what we've been taught culturally to expect in terms of body size and shape and weight. And so it's really fat phobic and a misnomer to call it atypical anorexia to be in a normal or bigger body size, because that is the most typical presentation of anorexia.
Totally. I
So you can't
love how you said that.
diagnose someone with your eyes. You
You
cannot
cannot.
diagnose someone with your eyes.
If anything, to just like really push that point, and send it home, only 6% are quote unquote underweight. That means 94% are not.
Exactly.
94% are not. That is
Yep.
a huge number of individuals. And this is what is really leading to a lot of changes in our clinical management, how we screen, et cetera. If anything, I hope that the more people learn about that fact, the more improvements we'll see with early detection, early recognition, and early prevention, truly.
And less
And
stigma, less shame, less gaslighting, right?
oh, amen, amen. And if anything, I love how you talked about with the quotations overweight, normal weight, underweight. Yeah, as if weight could be standardized, right? We have this system that tries to standardize us all to weight. And trust me, there will be another webinar on that very history of why is that our system. So stay tuned for those updates and announcements in the future. But if anything, whoops, sorry, jumped ahead. One thing, though, that I think is really important to talk about that crosses through so many of these quote unquote diagnoses, because it actually is a direct result of weaponization of nutrition, is this concept of body dysmorphia. And I'm wondering if we could dive into that a little bit before we go on and really name it for what it is. It's a delusional process, and it has to do with changes in the parietal lobe. So it's not a problem with your eyeballs, not a problem with your optic nerves, not a problem with your occipital lobe. It's where the meaning of the image your brain is processing is interpreted that is disordered and dysfunctional. It's so hard. When patients are reflected back, like, hey, I think you might be seeing your body inaccurately or exaggerated. There are lots of different terms and nuances, and it really is truly individual on how you help someone explore their body dysmorphia. But it's so hard when they say, but I see everyone else accurately. Why is it just me that I see inaccurately? And it is still kind of a mystery, right? Like we still don't fully know why body dysmorphia and this quote unquote delusional process only affects our own reflection of our image that we see. And I often tell people it'd be a whole lot more entertaining and easier to reality check if the delusional disorder was around seeing green fairies. If anything, it might be really entertaining and funny. Be like, oh, hey there, little one, I see ya. But I also know you're not there, so bye-bye, right? Like, how do you address body dysmorphia with your clients?
Body dysmorphia is really tricky and complex to treat, but I think something that everyone can relate to is kind of the term self-objectification.
Mm.
Kind of seeing yourself maybe like through like your own reflection and seeing that in a distorted way, which is based in the parietal lobe. But I think even people without eating disorders, it's normalized to kind of imagine seeing your body from another person's perspective, and how we have to really work to get into our bodies and experience our life in our bodies instead of constantly checking our bodies and imagining how
Mm.
others see our bodies. So it's a long and very important process. But one of the things I really like to give people is like a hot tip and a trick is to talk less about appearance in general, to maybe not comment or compliment even people's body size, weight, shape, or appearance. Because if someone has body dysmorphia or if someone has an eating disorder, what they hear is like, I got to keep engaging in my eating disorder, or I won't look good anymore, for example, even with a well-placed compliment. So I just think in general, as a society, we can just talk less about people's bodies and appearance, and it will help everybody get engaged better in their lives versus how they appear to other people. But yeah, body dysmorphia is a really tricky one, but it's treatable just like eating disorders.
Totally. Well, if anything, why do we put so much emphasis on interrupting behaviors? Why is it so problematic? And we want to make sure we're giving a moment to talk about malnutrition, because really any patient meeting criteria for an eating disorder should be considered malnourished regardless of weight state, because malnutrition affects every single system in the body. It affects your skin, your muscles, your tendons and cartilage, your bones, your smooth
Attention.
muscle. Oh, I didn't even get to the brain yet. I
Yeah,
mean,
yeah,
brain is like,
yeah.
we all wonder,
Yeah.
why is this so hard to interrupt? Well, the headquarters for all of our choices and decision making is also deeply impacted. I mean, goodness, the brain runs off of primarily glucose, right? It's the organ that consumes the most glucose out of all organs in the body. So when you deprive it of nutrients, it notices it immediately.
The brain, as the way I put that, is it's the most calorically expensive organ in the body, and we do
Mm,
not want to deprive our brains. I tell people the days that I'm sitting in the therapy chair all day are the days that I really do notice that I'm the hungriest, because my brain is working so freaking hard when I'm
totally.
doing therapy, as it should be, right? So, and it has no way to store energy. There's no way for the brain to store energy. So the effects of not eating at regular intervals. So I want to make sure to be really clear about this. It's not just about restriction. It's about eating in erratic ways, right? Eating in ways that your brain doesn't have trust that it's going to get regular intervals of nutrition and of glucose. And so it has to kind of cut corners. And you see that really, really quickly with the brain and with the body.
Totally. Totally. And if anything, this is why we worry about the longevity of someone's engagement with these behaviors when, again, the inconsistency of nutrition, weaponization of nutrition, because it's an additive injury process, right? Like,
Yes.
as someone goes through it, it doesn't matter how many times they weight cycle, perhaps it just continues to weaken and weaken and interfere with optimized processing.
It snowballs, right? It
Mm-hmm.
snowballs. It gets
Does.
bigger and bigger and worse. And
Well,
just to be like, not to be fatalist, but eating disorders are the second highest rate of mortality of all psychiatric illnesses. So they really are no joke. Like, we just don't want to mess around with eating disorders. It really affects all areas of your life.
yeah. And I mean, the quality of life too. And if anything, I want to bridge now to what you were talking about before of how much is culturally reinforced, right? When we compliment or make comments on other people's bodies. So I actually want us to kind of dig in a little bit of how society really interferes with our overall health and wellness, right? We have all of these concepts that our kids are exposed to, we were exposed to when we were in early education. But this is where it really does, or we really can exemplify that concept of a biopsychosocial illness, right? Like, what is affecting your body physically and your functions, your brain functions, and your mood and your ability to focus is deeply influenced by the cultural environment, by your family, by your friends, values that are defined for you, physical pursuits. I mean, diet culture alone, one of the most
Yeah.
toxic things ever, right?
Yeah. And our society normalizes the discontent with your body. Like, it's considered normal. And this is a really like heartbreaking comment about our society, but it's considered normal for people to not really like their bodies, not be at peace with their bodies, be constantly thinking about how to change or control their bodies,
Totally.
which is deeply problematic, right? And then we're kind of sold this bill of goods that there's one way to look, which is also constantly changing. If you look every decade, every 5 years, something's constantly changing, and there's geographical reasons for that because you can make more money by promoting a body type that's less available in that area. So, and we'll get into all that. But I wanted to just briefly mention, we're going to talk more in depth in time about the Fiji study. But one, really seminal study was that late into, I believe, the 1980s, there were two villages on the island of Fiji that still hadn't received electricity and therefore not Western television. So they were able to study the effects of the introduction of Western television in these two villages, which was virtually impossible anywhere else because Western television had already poisoned everyone. So they were able to document the really dramatic uptick of previously completely absent eating disorder behaviors and body image distress. Just so that just shows the cultural influence on eating disorders.
Totally. If anything, what I find really interesting about our medical system, and this is speaking as a pediatrician, is how much we focus on weight specifically, and then weight-based equations like BMI, right? When we know that BMI will miscategorize metabolic health 3 out of 4 times, something like that. So you cannot diagnose someone's health, as you said earlier, with your eyes, but also with a weight. Weight specifically could be you could have a group of people all weighing the exact same amount, and they could all look vastly different and have vastly different health or outcomes and influences. So weight alone is not an individual indicator of health either. And yet we have so much that focuses on just that biometric. It really takes away from our ability to individualize healthcare when we are constantly focusing on weight and honestly still acting from a place of sizeism, if we're being really honest.
Yeah, and sizeism just affects humans in so many really devastating ways, including
Mm-hmm.
like getting good healthcare, good access to healthcare, the ability to feel safe going to access healthcare, having places that you can feel comfortable and safe traveling or being in public spaces. Sizeism is deeply problematic. It's political, it's medical, and we need to uproot it and change it.
Totally. All right. Let's answer the
So,
question now.
oh, well,
Oh, go ahead.
let me do my little quote real quick.
Please do.
So,
Oh,
I'm
yes.
talking about body diversity, right? I think it's useful to think about dogs or to think about trees, that there's no one way to be a tree. There's no one way to look like a dog. That humans are just as biodiverse, and that most of the way that we look is just really programmed genetically and really kind of not up to us, and the ways that we do and don't achieve health, a lot of those are largely outside of our control, but we're kind of sold a bill of goods that we could just, if we just dial in our diet and exercise, we can look a certain way and we can achieve health. That's just really ignorant. There's so
Health.
many factors that relate to whatever health means, right? So there's a quote that I love by the radical body warrior, Sonia Renee Taylor. And she's talking about how an acorn, this is her quote, an acorn does not have to say, I intend to become an oak tree. Natural intelligence intends that every living thing become the highest form of itself and designs us accordingly. So I really love this idea that our bodies are going to become themselves. And it's not because, and that our purpose isn't to constantly shrink, control, or form our bodies into some hyper ideal that has nothing to do with us and is often really bad for us.
I love it every time. And I always have this image in my head of that acorn just living with that freedom where it doesn't have to think about its intentions, and how much we as human beings need to really cultivate that perspective instead of preoccupying ourselves so much with what will I be? What will I be? What will I be? How will
And
I
what do I look like to other people, right?
correct?
Exactly.
Totally. All right. So, what about disordered eating? That was one of the big questions we wanted to answer in this webinar. And if anything, disordered eating, is a term used to describe a wide range of harmful eating behaviors that may not warrant a full eating disorder diagnosis, which really means it's subclinical at that point, right? So, this is less of a Venn diagram and really more of a spectrum or a continuum of symptoms and the severity of those symptoms, how much they're interfering in life. And if anything, when we look at this picture, for example, normal eating, if anything, do you want to describe what you would often say is normal eating or normalized eating?
Yeah, I think normal eating is that you think about your food, you think about food most likely when you're hungry. And then you pretty much stop thinking about it when you're full. And then you occasionally think about your body, maybe when you're getting dressed or you glance in the mirror or you're doing something where maybe eyes are on you. So you think about food and body some of the time, but it's context specific and it's pretty relevant to what's going
Right.
on.
And
Disordered,
culturally influenced too, right? Like it can be different
yes.
person to person, and definitely cultural and ethnic backgrounds also influence what is normal, right? But it is, as you said, it's being able to eat flexibly and oriented towards hunger and fullness cues, pleasure, and those social circumstances that we are all encountering.
Yeah, it's like thinking about food some of the time, giving
Yeah.
some attention to food selection. But disordered is kind of, I think of a volume knob. It's just turning it
Mm,
up to maybe that mid-range where it's a little louder. Maybe it's a little bit more uncomfortable. You're getting a little bit more rigid about that, like less flexible, more rigid about food, thinking about it more, obsessing about it more. Same thing with movement. And unfortunately, disordered eating is pretty normalized and praised in our society. So people saying things like that they need to work off food or need to earn food, those are considered normal in our society. And Dr. Knopf and I would say that that is absolutely not good. It is disordered. Also like orthorexic tendencies where it's like there's good foods and bad foods, like morality around food, being really like counting like types of food or amounts of food, reduced food variety and anxiety around trying new foods, skipping lots of meals, frequent dieting, that moral value assignment to eating and eating in secret, preoccupation with weight gain or weight changes or body changes, and then poor emotional regulation. Those are all kind of in the realm of that medium volume disordered eating. And then when we pop the volume all the way high, I would say most people with an eating disorder, they're thinking about food in their bodies a lot, like probably most of the time. Would you agree with that assessment?
Oh, totally. It's that constant preoccupation, constant weighing consequences of choices through only one specific lens. So it's almost like a monomania, right? Like only one focus of their entire life. And if anything, as you said, with the volume being up, they also are now having dysfunction in those other realms of their life. Maybe it's affecting their relationships, their ability to be present at work. They're missing out on social events because, again, the thought of eating in a different environment out of your control perhaps could be one of those features that someone is contending with,
Yeah,
right?
travel opportunities, because it's like, well, I don't know what food will be available and I can't control it. That's another hallmark, right?
Totally.
It's really missing out on your life.
And if anything, what I find so amazing when we think about this being a continuum or a spectrum, we will say more about dieting in general and why dieting doesn't work. So again, wait for that announcement for that webinar. But 35% of normal dieters will progress to pathological dieting, which is disordered eating. And then 20 to 25% of those will progress to partial or full syndrome eating disorders. That's a huge amount of people who
Yeah.
maybe said they just wanted to make a healthy change. But this is where that biological click of the body sensing inconsistency in nutritional intake or caloric use changes how the brain functions and changes how the amygdala, which is the central point for fight or flight, the anxiety home of the body, where survival is the most important aspect, really gets turned way up. And then we see these things snowball, as we've talked about before.
Exactly.
All right. So we talked about it being a spectrum. What do we do about that? What do we do when we encounter someone who has disordered eating, may have an eating disorder upon further assessment? What happens next?
Okay, so first and foremost, I want to just mention that sometimes people with eating disorders, they know something's up, but they really can be like in pretty hardcore denial about it, or truly think that they don't have one. That's
Mm-hmm.
sometimes a hallmark feature of it. So it really does take an expert to help assess and diagnose. So if you're worried about a loved one, or you yourself have been diagnosed, please, get an assessment. And then the gold standard for treatment is going to be a therapist, a dietitian, and I want to make a caveat about both of these, that they need to be eating disorder trained. A psychiatrist, ideally eating disorder trained, but I always say you're like a unicorn, Dr. Knopf. It's really, but unlike unicorns, you exist. They're just really hard to find, like unicorns. And then just a primary care physician that can determine medical stability at regular intervals, and a group therapist, if possible, to attend group therapy. Anything you'd add to that?
Well, if anything, can you elaborate a little bit more about the group therapy dynamic and why you see that being so pivotal to someone's journey out of their eating disorder and into recovery?
Oh my gosh. Eating disorder group therapy is some of the it can be really magical in terms of accelerating change and helping people find community and validation and awareness. People just suddenly light up like a Christmas tree when they're talking to people who really understand what it's like in the day to day having an eating disorder. And then it really helps to see people who've gone further along on the journey of recovery, as well as being able to see how far you've come on the journey of recovery. And I've treated people both in individual and in group therapy. And I will just say that there are really unique factors that accelerate change in both modalities that are impossible to have in the other modality. So if possible and if accessible, having both of those modalities is really ideal to accelerate change and to really enhance and protect recovery.
Totally. I love how you talked about that. I really think that sense of belonging is something I think most people I've worked with, you've worked with, have talked about, where there's this sense of isolation. People don't get it. And so not only being able to find community, which we are also really happy to expand our community services, right? But I
Yes.
think it's so important to also have that opportunity to know that you can share what you really think and feel without shame or guilt and have it processed in that group setting, right? I think you even told me once how it can help play out dynamics that may have shown up interpersonally, that when they are in their normal lives, it's faced with more opposition or conflict. But in a group therapy session, you actually have more opportunity for reflection and feedback. So it's a
Yeah.
different type of experience as a whole.
Yeah, you can get all the influence and perspective and insight without any cost to your personal life, because it's private and it's separate from your personal life. And I personally think group therapy is one of the places where you can get some awareness about yourself and your group dynamics that are pretty much impossible to get in any other setting. So it's a really incredible addition to standard treatment.
It
I
makes
think
me
it should
want,
be standard treatment.
right? It honestly makes me want a group therapy opportunity for providers,
Mhm.
right? Not just our
Yeah.
supervision groups. But if anything, what you were delineating was that multidisciplinary treatment team, right? And it really comes
Yes.
down to there are so many different facets of this boulder that we're trying to break down, that you need to have those different perspectives and foci, I was going to say,
Modalities. Yeah, I would
modalities
say
to
going
break it
back to
down.
my like kind of cancer metaphor,
Mm.
it's like depending on the cancer, of course, and I'm not an oncologist, obviously. However, but like a lumpectomy, radiation, chemotherapy, and medical treat like or medication treatment,
And
you're going to have the
therapy. They add therapy.
and yeah, and group therapy. People with cancer do group therapy too. Like the more you can hit it, the better chance of eradicating and preventing relapse. So eating disorders are complex, they're severe, they're significant. We want to treat them the same way.
Totally. Well, thank you again, Dr. Hannan, for joining me for Doc Talk. Thank you to all of our participants as well who have tuned in. This will be available in the community. It will be stored there as a recording later, and stay tuned for more Doc Talks every Friday. We might have a couple of exceptions, but in general, every Friday, 12:30 Mountain Standard Time, we will be here.
Bye.
Bye, everybody.